Okay, here we go. So we're going to talk about neoadjuvant or perioperative EV pembro. I'm not going to go through the detail in huge detail, the slide in huge detail. It was originally a 3-arm trial. Oh, sorry, it was originally a 2-arm trial with single agent pembro. It became a 3-arm trial. It became a 3-arm trial when it became apparent that EV pembro was super active. I think some of us will probably, I think Matt, you were definitely involved in those discussions. I was involved in some of those discussions back in the day as well about how one would approach this. There is a question about whether it would have been better to do a really pure trial or whether this was the right approach. The trial's not huge. It's not the biggest trial randomized phase 3 I've seen in my life. And there'll always be noise and forest plots associated with that. It was a cisplatin ineligible trial. And that's really important because we know in the cisplatin eligible population, neoadjuvant chemotherapy and durvalumab is currently a standard of care. In the control arm, there wasn't adjuvant nivolumab. That may be important, although it never hit overall survival, did it, Matt? Let's be honest. So,
I'm sorry, I'll pull you out.
Can we keep track of how many times you say that?
I apologize, Matt. It never hit overall survival, but you could say it was a standard of care, but not for the conduct of the whole trial. And actually, when the trial started, it wasn't. And I don't think changing your control arm in mid-trials is a good idea. Having said that, it's a caveat associated with it. There's obviously some issues around the duration of therapy we need to perform, but one has to say that the results are incredibly striking. And I think they're transformative, and I think everyone I've spoken to agrees with that. So what I wanted to talk about today was how transformative those results are. I showed those 2 forest plots just very quickly, just to say that there is this cisplatin ineligible population that was included. And I know many of my friends and colleagues think this applies to a broader population than the cisplatin ineligible. And also from here, you can see maybe the performance status 2 patients doing slightly better. Does that suggest to us that this is getting hold of systemic disease, not really focusing on the primary cancer very much? And actually, for those patients who are in harm's way, obviously giving really effective systemic therapies can be better than doing a big operation and delaying that. So I wanted to show that slide to start with. I think this second slide here in round PathCR is also important because we've never seen a PathCR rate above 50%. I've said for a long time, if it was above 50%, it would totally change my approach to the disease because I didn't think we would achieve that. 57% versus 8%, I think is transformative. So why don't we start with you, Jonathan? You did the discussion at ESMO. What was your take on the data when you first saw it and you thought, how do I construct a talk around this? What was your main theme? What was going through your mind?
So, when you're faced with such positive data, you start looking, are there reasons that could explain this that aren't because of the efficacy of the agents? And there really weren't holes here. I mean, the hazard ratio 0.4 and 0.5 were really, undisputedly tremendous advances. I think thinking about where does this take us as next steps, I think the adjuvant phase is the area that is sort of the weakest area in a sense, and that only 2/3 of the patients went on to receive it. Yet despite that, the outcomes were spectacular in the trial. But we don't really understand why that third of patients didn't go on to adjuvant therapy. And I think that the contribution of phase question is something we're going to struggle with for a while as a field to try to break down what we want. Does everybody need the adjuvant portion? Because my guess is not everybody does. Or do they need adjuvant EV and pembro? And so these are the questions we're gonna be looking at over the next 5 years, I'd say.
Matt, what are for you the things you didn't see that you wanted to see that you think we need to look at before, what would you do? What would you like to see next?
I mean, I think there are the obvious things in terms of where the field is going. ctDNA is of interest in this study, but I think, the data, as you said, speak for itself. And I think, the study is important for many reasons, but it's important for a few specific reasons. It's the first phase 3 study in this space. We oftentimes forget that, but this is completely new territory. The second is that I think there's this notion that cisplatin ineligibility in the metastatic disease and in the clinically localized disease means the same thing, but I'm not sure if that's true. And I think in muscle invasive disease, it might be a surrogate for size and aggressiveness of local tumor, because many of these patients were ineligible based on renal insufficiency, which is due to ureteral obstruction. And if you look at the control arm in this study, patients did horribly. And so I think it really opens up this this new population of patients for systemic therapy for the first time.
Carla, you and I chatted about this beforehand, like 20 minutes before we started. What was your take on it, and what have people been talking to you about in terms of approaching these patients in the future? And is the population, because there are lots of patients who we've not put forward for cystectomy in the past, and they've ended up sort of getting kind of radiotherapy or nothing. Does this extend that population? Those PS2 patients who seem to do the better, it's a forest plot analysis. Do you think you're going to be treating more patients than you were before? Because lots of patients who we see with muscle invasive disease don't, of every 5, we see 2 of those end up with radiotherapy or nothing for various reasons. Is this extending that population? Because the medical oncology community never won the debate. I still don't think we have on neoadjuvant chemotherapy, in that when you go around the world, many people are still doing surgery and then they're doing a decision about adjuvant therapy. Does this change the field, and does it make the pool bigger?
Yeah, I mean, I think a couple of questions in there. So I think first off, I think it should, and it does, because I think it opens a door to give something in the neoadjuvant setting. We've been sort of married to the cis-eligible, cis-ineligible for a long time. I agree with Matt. In the MIBC setting, I think it's a different discussion altogether. But these drugs, EV plus Pembro, changes that discussion. So we're not pigeoning patients into holes of cis-eligible and ineligible, and as such, we may broaden the population of patients eligible in the upfront setting. That's the first thing. These PCR rates are really stunning. They're exciting. And I would argue that we may even see these rates when we extend to the cis-eligible, which not this patient population, but we'll get those PCR rates. And then the next question will be, can some of those patients potentially spare their bladder? We've talked about this, of course. Do we need to be doing cystectomies in all these patients? So I think that'll be the future as we try to answer that question. And if they don't, moving next step, if they don't get cystectomy and they get, say, bladder sparing or trimodality or something, can they get the adjuvant component of this treatment? I think it's important to consider that on.
We're going to talk about that in a second. And Josh, I'm going to ask you at the moment what this means to the US surgical community. But Jonathan, I'm going to start with you. There's a study out there called B15. It's GEM-CIS as the control arm. It's the Niagara control arm versus EV Pembro. It's a bigger study. It's all details on clinicaltrials.gov. It's a more robust trial. It was I thought it was a more, it's the one that I thought was going to come up closer to, a very robust, very, very positive. Guess me the path. I want to hear from you what your prediction of the path CR rate and the OS hazard ratio of that trial is.
I think the PAT CR rate will be a little higher than this trial, because 66, 67%.
67%. You're going to be out of business, Josh.
And
Okay.
hazard ratio
OS.
for OS 0.65.
6.5. No.
I was going to say the exact same thing, except 60% for PAT-CR in same hazard ratio.
Carla.
Same idea. I was going to go about 66, 67%.
Huge
No.
expectations. Josh, this sounds depressing for an up-and-coming cystectomist. Because at the moment, the surgical community remain the gatekeepers of muscle invasive and non-muscle invasive bladder cancer. One would imagine that if all of these patients end up getting EV Pembro, and certainly if Jonathan's right and those results come home, that sounds like the case. Will this become an oncology specialty, like, dare I say it, kidney cancer, those patients that still have a primary tumor in situ, they get Axi-Pembro or whatever regime, I don't know whether, and then they have delayed surgery maybe. Are we in the same place, or what do we need to see to get to there?
I mean, I think you have to look at the whole thing as a perioperative bundle, right, from the beginning to the end. And the surgeon is sort of the middle part of it. Well, first of all, we're at the diagnosis part. Our goal is to get them to you, right, and say that this is an important part of your care. This is probably more important than the middle, which has either been surgery or TMT. But I think to your point, if you're hitting 60% cure, then the disease shifts to becoming keeping bladders and NMIBC, and what's the best strategy to prevent those CIS stage 1 muscle invasive recurrences. But then there's also going to be patients who are metastatic and not surgical candidates who are going to have local disease afterwards. So I mean, again, our goal is not only patient preservation, but organ preservation. So I think that's all part of it.
Does anyone on the stage think that cystectomy, as in 5 years' time, cystectomy followed by something, is going to be the standard of care? Or is neoadjuvant some form of treatment just going to be the standard? Or are there any cystectomy patients left, assuming the study with the cisplatin study comes home in the way Jonathan describes? Are there any patients who say, oh, this one's a cystectomy? Who might it be? Okay, Matt, far away.
Yeah, I mean, I think we're biased by the patients who we see, and those are the patients who we remember. But we forget about the patients who present with bleeding and ureteral obstruction, are diagnosed in the hospital, are actually diagnosed in the hospital during the same admission that they have their cystectomy. So there's always going to be patients who go straight.
But that's not many patients.
I think it's hard to estimate the number.
10%, 5%, 2%?
Well, look at the number of patients who are getting neoadjuvant therapy right now. There are multiple reasons for that, but it's nowhere near 90%. But this is more like 40 to 50%.
But the neoadjuvant benefit was, the quote was 5% OS benefit. And my surgeons, which I support 100%, that's still the number they come up with. That was a bit better with durvalumab. It's a step in the right direction. But this seems transformative.
In our eyes, it is. But I think there are people who believe that the knife cures all. And so there's a lot of education and convincing to be done to translate that into practice.
Let's move on. 4 key questions with this data. The first is around Josh's point on the control arm, which did really poorly. Is that control arm contemporary? I would have assumed in the current age that those patients who are fit for cystectomy, we could pick them a little bit better. I mean, most of those patients, the cancer's metastatic within a year or so. Did we pick the wrong population, number one? Number 2 is, there was the third arm in the trial, the adjuvant, the pembrolizumab arm, that was the original arm in the trial. Surely the follow-up of that sounds long to me. Why haven't we seen that, and when will we see that, and is that important? Question number 3 is the cisplatin-eligible subset I showed you, as confidence intervals were wide. It was a small population, but it wasn't quite as compelling as the cisplatin-ineligible population. Can we translate these results now into the cisplatin-eligible population? And then the third question, what's the role of ctDNA? Do we need those last 5 adjuvant cycles, as Jonathan suggested? I'm going to go through these very quickly, and then we're going to discuss, if I may. So the first issue, there was a study back in the day. We did the CMV trial versus best supportive care, surgery alone. It goes back, you could pick a different study. It was the positive trial, as you can see from here. And looking at the control, I mean, it's 20 years ago, and the control arm of this, the 2 arms, are somewhat similar. We haven't seemed to have made any progress in that population over a 20-year process. So was this an unlucky population who took part in this study, or is it just that's what you get if you do cystectomy? And if that's the case, Josh, this is surely an indicator that we should stop doing cystectomies on these patients.
I mean, again, as Matt mentioned, there's 2 types of cisplatin ineligible patients. There's people who have a little bit of hearing loss and they can't get fit surgery because they can't get chemotherapy because they don't meet, all of Matt's criteria. That's one thing versus someone who comes in with a massive tumor obstructing their, and there's nothing for them, right? They're not metastatic, they're localized. When you look at that patient, they're not going to do well, but there's nothing in front of them and they're not metastatic. So I think those are very different patients, and I think that actually the control arm is contemporary before this.
So nothing wrong with the trial. This is what's happening every day in the clinic. Yeah. And Jonathan, the way I've been looking at this since I saw that curve was that actually performing surgery in patients with MRD, with micrometastatic disease, in bladder cancer, actually puts them probably in harm's way. Because you wait 2 months to do the operation, or 6 weeks around the world. During that time, it's growing. And then you do this debilitating operation. They spend 3 months recovering from it. You're then 6 months down the line. And by that time, these micrometastatic things have become apparent and the patient's getting into trouble. Shouldn't we be, this is a systemic disease.
Right, right. I mean, we've known for a long time that it's a systemic disease in about, at least half of patients. And in those patients with high tumor burden, deeply invasive tumors, the high-risk muscle-invasive patients, that number is probably even higher. And so, I mean, this is highly effective therapy, given upfront the most effective therapy we've seen so far in bladder cancer. It's not a shock that we get much better results when we give much better treatment. And, the benefit compared to cisplatin-based chemotherapy, I mean, when you look at EV302 and extrapolate, it's going to be a real improvement there, as well as my prediction of, you don't have to be a rocket science to predict that, right? But early treatment of micrometastatic disease is the key. And I think, in the academic centers, we get it. It's really reinforcing it in the community setting where the urologist has to send the patient to an oncologist or decide they want to do this. They may not want to do that. But we need to make sure that the education is there to understand that we actually have something for those patients who you think can't get anything. Maybe there's some caveat to that, but.
And Carla, looking at the path-CR rates, looking at the shape of the indirect comparison with Niagara, where does this land now? Is this EV-Pembro, for everyone? Does Gemcis, durvalumab, perioperatively, does that still have a role? Do we need to wait until the randomized trial against Gemcis comes out, or have you made your mind up already? Where do you sit with this creep into this cisplatin eligible space, and come to that point where you said before, where in 2 or 3 years' time, as in metastatic disease, the Gaussky criteria will die, Matt? Are we there today, or do we wait till tomorrow?
Yeah, I mean, I think one of the things I'll say with EV from very early days, response rates have been pretty consistent across the spectrum of the disease as we move it earlier. We've seen that with EV, we've seen that with EVP. So I anticipate we're going to see the same response rate, cis-eligible, cis-ineligible in the neoadjuvant setting. I think that's where we're going to be. And I think when you ask about Gemcis Durva, I think if you don't have access to EVP, I think Gemcis
But if you do
Durva
have
would
access?
I would do EVP. I think the response
Matt,
rate.
where are you?
Yeah, I mean, I think the main lingering question is that we don't have so many therapies in this disease, even though we have better therapies. And so if there is potential non-cross resistance between these regimens, and some patients might benefit from platinum-based therapy versus EVP, I think that's the salvage for that regimen. Otherwise, it's EVP for everyone.
I mean, I think that's where we're heading, but
Are you there yet, or are you going to wait for the randomized phase 3 study that's...
I think on a practical level, I'll have to probably wait for the randomized phase 3 trial.
But if not practical,
If
are you,
not
are you still
practical, I'm there. I've been
Someone
there
comes
for
in
several
tomorrow and
years.
says, I want the best treatment.
Listen, the definition of cisplatin ineligibility was very elastic when when EV103 led to the approval in the United States, right? Everyone had a reason to be cis ineligible. It's going to happen again, I think, once there's regulatory approval. And even private insurers are now starting to allow us to do it in selected patients, particularly those with higher, one node that's enlarged. We're getting approval.
And just a quick comment that, the cisplatin declining aspect of the study, that was added later in an amendment to try and make the study accrue more efficiently, because there was a request to do that. But that's a very small subset of this study, and I would not look too closely at that subgroup analysis.
But then you shouldn't adopt it into the cisplatin eligible population. If you want to be a purist, then be a purist, Matt.
No,
You can't say, we'll exclude that because it's small in the study, but I'm going to do it anyway.
no, I'm not saying that at all. I'm not saying.
What exactly are you saying?
I'm saying that you should not use that to predict what's going to happen with B15, because that's not a fair assessment.
Josh, tell me how does the surgical community care what neoadjuvant therapy the oncologists give?
I mean, I think so, right? Because you want the best outcome for your patients. Like you've known that patient now for a while already before they get to you. So we're already invested in them. And I think it's a hard spot today when a patient shows up and says, what should I get? And you're like, well, I know this data is out there that people do really well with EV Pembro. So, but it's not FDA approved in the US at this time. So how do we get them there? So I think we're in a bit of a gap, but that's usually what I'm thinking is how do we get them the best path response?
Jonathan, when you looked at the trial for the first time as the discussant at ESMO and you saw that the third arm was not being presented, on a scale of 1 to 10, how disappointed were you?
1.
And why were you? I was much more like a 7. Why do you feel differently to me about this?
I mean, I think, we've seen the role of single agent checkpoint in the adjuvant setting, and I didn't think that the neoadjuvant period would add a dramatic amount, and so I wasn't surprised that the data was not matured. And because watching Ambassador from up close, these are the single agent ability I think the events are probably tracking. They're either doing really well on both arms or, we just haven't had enough events in the trial yet, but it's not surprising to me.
So you don't think that arm is read out yet?
Well, I don't know. I assume it's not read out yet. I assume we would have heard.
So we would have heard if you would have heard if it was positive or negative.
Right. But it was, it was stopped early, right? So
I mean, to your point about
stopped accruing early.
Because just before we come here, Matt, if I may, the path CR rate in the Pure 1 trial is 37%, which is not that bad. Now, there is a single-arm trial, but it had 120 patients in it. If you look at the landmark OS in the Pure 1 trial, and I know it's a single-arm trial from a relatively small number of centers, but Abacus showed the same thing. The landmark doesn't track that far. It's not that far off.
Yeah, but we did a single-arm trial of nivolumab in the neoadjuvant setting, and we had a 15% response rate, yet nivolumab is clearly an active drug. So I don't think that, I think in large randomized trials, single-agent therapy has never really truly shown dramatic benefits. I mean, they're modest benefits.
And giving upfront systemic therapy would have got in control of some of those people in desperate harm's way.
A few of them, but not necessarily the worst ones.
Oh, sorry. Matt, where are you on this? I interrupt you.
Oh, I was just going to say that I think this is a beautiful example of adapting to the data and trying to move the best treatment into a position where it could be available to the broadest number of patients as quickly as possible. So you know how long it takes to design and implement a phase 3 study to be able to latch on EV Pembro to an existing neoadjuvant. I mean, how many years did that save? So I understand your points about the heterogeneity, but this is real, like pragmatism in action.
We're going to move to the difficult part of the discussion. INVIGOR-11 was a randomized phase 3 study. INVIGOR-11 was born out of INVIGOR-10. And in these trials, we showed, INVIGOR-10, we showed that ctDNA positivity was present in 40% of patients, 40. And post-surgery, those patients who were positive did better with atezolizumab than best supportive care with a hazard ratio of 0.6. And those patients who got best supportive care, who were CTA positive, almost all of those patients relapsed. In the CTA negative population, the 60%, what we showed was something slightly different. We showed that the relapse rate was about 30%, and the hazard ratio for atezolizumab in that population was what per PROAS was 1.1. So it looked like it wasn't helping and they weren't at huge risk. And actually, Matt, your recent data for nivolumab, without going through the details of that data, it was a slightly less big sample size, but it was the same Signatera personalized approach. Showed very similar retrospective data. And again, this prospective trial was launched a while ago and was hard to recruit to. Screened 700 patients, and those patients had regular ctDNA measured for up to a year. And if they were positive at baseline, or they became positive during that year period, they were randomized to receive atezolizumab or placebo. And in that population, that randomized population, you can see the hazard ratio for survival was 0.59. There was also an EFS benefit, 0.64. It's the first and only OS signal with atezolizumab. 11 trials we did, 6 randomized trials. The last gasp, the last study was the positive trial. Well, I think it was the best. Maybe. But anyway, the issue is there was also this negative population. And in that negative population, 360 patients that were tracked and remain negative, because remember those positive patients were randomized in to receive atezolizumab or placebo. In those that remain negative, their outcome, as you can see, was excellent with 97% OS. Now there's some censoring in these curves. It's not possible in any of the trials we do to cover all of these patients all the time. There was a second trial called Tombola out of Denmark. I think an excellent study also. More complicated because it was a single-arm trial, but the design was somewhat similar. They looked at the OS of the patients who were negative, who remained negative, but they didn't randomize the positive patients. And in their study, 100% of those patients who were negative, who remained negative, remained alive. So the question for you as a panel is, we've got a positive randomized phase 3. Does this make any difference to any patients in view of what we just talked about? And does it help us, really importantly, if the answer to the first question is no, and Matt said there's still some cystectomy alone patients, but not that many. If the answer to the first question is no, does it help us talk about the duration of that adjuvant pembrolizumab and that adjuvant EV? Do we need both of those drugs? Who would like to start with that? Far away now.
So an incredibly important study. I think it shows a couple of things incredibly well, and it doesn't show a couple of things. So what it does show is that if you have detectable ctDNA after surgery, you need adjuvant treatment. I mean, maybe that's a no-brainer, but we hadn't determined that prospectively, so you've nicely shown that. The other thing that you've really nicely shown is that molecular recurrence is a clinical disease state that we can intervene on in a meaningful way with an intervention and improve outcomes. That's never been shown before. I don't know that that's been shown actually in any cancer yet. And so that's an incredibly important finding. And we have patients who decline adjuvant treatment who are being followed with ctDNA after surgery. So when that patient's ctDNA becomes detectable now, I have a phase 3 study to say I should treat that patient rather than waiting till they have recurrence. I think the undetectable ctDNA part is a little bit more challenging to dissect because you have to make a treatment decision when you see a patient for the first time after surgery. You don't know that they're going to be serially undetectable. And just based on the concept of conditional probability, a patient who remains undetectable is going to do well, and you can say that with basically any assessment that we do, a PET scan, CAT scan, et cetera. So I think that part's more challenging.
And Matt, but we could salvage those patients that become positive with atezolizumab.
And you can say the same thing with PET scan. So if you did the same study with a PET scan instead of ctDNA, and you took the patients out who developed radiographic recurrence on conventional scan before PET scan, and then you moved the patients who detected PET scan positive disease, randomized them to placebo, I bet you would have shown the exact same thing. Now, ctDNA is more sensitive and more specific, granted, but you don't have that information when you have to make a decision after surgery.
But we know radiological relapse is too late. The durvalumab trial showed us that immune therapy and monotherapy wasn't that great once you got measurable disease. The question I've got to you is, because we're identifying these patients much earlier, are we creating a longer runway, allowing the immune therapy to work? And is there a group of patients, there clearly are a group of patients who are benefiting, otherwise all of the other atezolizumab studies wouldn't have been negative and this one be positive.
So by extension, then if you wait till molecular recurrence, then those patients had cancer. They didn't suddenly develop cancer. So then you move even earlier to the immediate after surgery setting. So
Jonathan, do you think what's your take on the study first?
And there's not a lot left to say after Matt eloquently went through.
So what I would like you to answer for me then is, what application does this have for Niagara and for EV Pembro? Because none of these patients had received immune therapy before.
Right.
And that's a real problem because this was a trial to show when to start immune therapy, not when to stop it.
Right. It
So-
doesn't really help us very much
Well,
in that
absolutely.
setting.
Right.
It really doesn't. I think the people coming through neoadjuvant therapy negative before and or after surgery, we know it's a better group of patients based on the data from Niagara. We know that the being negative at any time point, as you've said, is a good thing. But it doesn't inform us on what we do now in the post-op setting after EV Pembro. I mean, if they're negative, does that mean we're safe to stop? I'm not convinced yet, and I'd need to see more data. I think, one of the things that we sometimes think we're smarter than the trials, and the trials we design are really the only data we have, and if we deviate too far, you don't really know what you're getting.
Right.
And so, my bias is that until we show that adjuvant portion of these regimens is not worth doing because it's not going to help you, we should be giving the adjuvant portion. But I really would love to generate the data to tell us whether that we're wasting our time in the subset of patients. And that's where ctDNA can help us a lot more than just doing a randomized phase 3 trial of 3 adjuvant.
Josh, what I'm hearing from these two is that this trial was a huge undertaking and all the bits and pieces, the happy bit that goes with it. But I'm not hearing from either of them that this is changing their approach to the disease in front of them when EV Pembro becomes available. Will it change the minds of the surgical community to use more ctDNA? Or do you think people will look at this and say, it's a historical adjuvant trial, the world moved on, it was a nice piece of work, but it didn't change anything?
Yeah, I mean, I think after an operation that it's not easy for anyone to get through, and then you're pushing to get that therapy started in patients with high-risk features. If they come out ctDNA negative and they're not quite ready, it gives you a little bit of breath, right? I think that's the main, like how I changed my practice the next day. High-risk features, the patient needs therapy, but they're not quite there. Do we have a little bit of time to let them get better, or do we risk starting adjuvant therapy? That's the generalizable thing that I took from that as a surgeon.
I also think that one important thing is that this trial showed that ctDNA monitoring impacts outcomes, and that we didn't have that in a prospective fashion before. We had good retrospective data that might have satisfied a lot of people, but I think, I don't know what it says about atezolizumab per se, but it says that ctDNA monitoring
Brilliant drug.
is it's not a drug we're using anymore. So I don't know that it's going to rescue atezolizumab bladder cancer. But I think what it's done is tell us that we really have to pay attention to ctDNA because it really is a useful biomarker to help us understand what to do. But now we have the clinical question has changed. And so we now have to answer the new clinical question.
Yeah, I just wanted to pick up on one thing that Jonathan had said, and I think we have to be really careful about tearing this regimen apart and say, well, we're going to give the neoadjuvant, but maybe not the adjuvant. The data is the data, and the data involves the whole regimen as it is. I agree completely that I think we need to start generating data to see what happens in the adjuvant setting, maybe at the ctDNA level to understand that. And maybe ctDNA will help us in situations kind of along the lines of if someone's having a ton of toxicity and they're having a really difficult time, does ctDNA give us any information in terms of holding back? But we're not
The
there.
question I want to ask you then is, I want you to put something on that. So when can you not give the 5 adjuvant EB cycles? When and in what circumstances do you not give it? We know from the trial, Jonathan said, many patients didn't start it, and we don't know yet what happened to them. What we'd like to look at those patients, but it'll always be a bias, because retrospectively, why did they stop? And because they had more benefit, et cetera, et cetera. Did some of the PathCR patients stop because they were doing better and didn't feel they needed it? So we won't know until we do proper studies in that. So Carl, tomorrow, when a patient comes back to you and said, I really struggle with the 3 cycles, I don't want the EV drug, I've had a PathCR, I'm in the 57%, I don't want it, what's the answer to the question?
Well, I would say my recommendation is to try to do it.
All
And
5?
Yeah, I would go for that. And if they can't do it, then you'll back off. But I think the data,
There's not one circumstance where you would say, we're not going to go for it.
I'm
I
not
think
there
the
yet.
toxicity,
Yeah, toxicity
like,
would be like,
if they've gotten through 3 cycles and they have bad neuropathy or they had a bad IRAE, of course you're not going to give,
Yeah, sure.
right? That's the
But
population
they just come back
at
if they
the
don't want it,
moment.
Jonathan. They'd say they've come back, they've got their ctDNA, they're ctDNA negative, they've had a PathCR, and they said, look, I've looked at the data. There was that brilliant InVigor11 trial, which showed you I don't need this drug, and I don't want,
Right, well, that wouldn't be the recommendation. I guess what I would say is that's not my recommendation. You're an adult, you can make a decision not to do it.
No, I'm certainly not in.
So there's no scenario at the moment. Is there a trial out there right now? There's the Volga trial.
Right.
And let's talk about Volga right now. It's 3 cycles. Now there's a DV, Durva, Tremi, there's a triplet arm. I don't want to talk about the triplet, because this is in the CTA4 discussion. In the doublet, Durva plus enfortumab vedotin, very similar to the trial we just saw, the 905 trial, but they're not giving the adjuvant. Is it going to be a positive or a negative trial? And what are the results of that study going to be?
They're giving adjuvants checkpoint.
Excuse me, yeah, so duvalimab, pembrolizumab, duvalimab, EV, 3 cycles, surgery, and then the remaining year of duvalimab versus surgery alone, and there's a third arm with the addition of tremelimumab. What are the results of that trial? Carla, you go first. I want to know the pass CR rate and the OS hazard ratio.
I mean, I think the pass CR rate will be, I don't know, I'm going to guess, say, 60%.
60%, Matt?
Yeah.
OS.
See, a hazard ratio 0.6.
0.6?
Yeah.
Matt?
Yeah, I would expect the path CR rate to be pretty similar to 905. And I think the effect size might be slightly less.
I think I'd agree with Matt in that. I do suspect the adjuvant portion helps some patients, but I don't know who they are. The adjuvant DV.
And how are we going to determine, because if it comes back with OS of 0.6 and pass CR the same thing, Josh, then surely people are going to say, well, it's the same, you don't need that period.
Right. That's what patients many times will say, right?
So if that trial comes in with similar positive results to the 905 study, then that
So
adjuvant
I think if it looks like pretty identical based on hazard ratios and pass CR rates, then it's going to be a hard time to argue for the adjuvant portion, right, of EV, checkpoint notwithstanding. If it comes back a little worse, then, I think that's where
what does
ctDNA,
worse look like?
OS 0.65, hazard ratio of 0.5 for DFS, EFS, right?
EFS 0.5,
0.5, 0.65.
0.65. Matt?
Yeah, I agree.
But
Then we're starting to, if it's this intermediate scenario, I think then the path outcomes from the patient really that matter, and the ctDNA matters more than if they had a path CR. But this is all conjecture, I mean, we have, beyond not seeing the data,
is
obviously.
there any other way, is there any other trial that you're aware of where we are going to determine the duration of therapy in a randomized way in this setting? Or are we actually stuck with the 9 cycles unless Volga comes home?
So modern includes patients who have received neoadjuvant EV pembro. In the control arm in patients with undetectable ctDNA is Nivo alone, similar to Durva alone.
Do you want to just say the model? Why don't you give the tail ones the design model?
So in modern is a study of adjuvant immune checkpoint blockade guided by ctDNA. So patients meeting the same criteria, pathological criteria, is shown in this slide for InVigor11, have ctDNA testing using Signatera after surgery. If they have detectable ctDNA, they're randomized to nivolumab plus relatlimab versus nivolumab alone. They have undetectable ctDNA, they're randomized to Nivo alone versus surveillance, similar to InVigor11, and then treatment with nivolumab if they develop molecular recurrence. That study now includes patients who have received neoadjuvant EV pembro. In patients with undetectable ctDNA after surgery, the control arm again is Nivo, not dissimilar to the single agent Durva on Volga. And so what we're thinking in terms of thinking about how the chess pieces are moving over the next year, if Volga is similar, then there's the question about what adjuvant treatment is used, and modern sort of addresses, can we use ctDNA to make that decision?
I've got one thing I want us to talk about, and I want you to have a think about this before we wrap up. I want to ask each of you a trial that you'd like to see that hasn't been thought of yet. I know that's a challenge, but that's what I'd like you to do before we wrap up. But before we do wrap up, the most common question, we've got a few minutes to talk about this, is that the patients who have a pathological complete response who come to see me, the first question they ask is not fabulous, my cancer's been cured. They're saying, why did you cut my bladder out? The other issue is path CR in the bladder is not a sign of cure of the disease. It's just the thing that kills patients isn't what's going on in the bladder. The thing that kills them is metastatic disease. All that's happening is if the primary site has responded, we're kind of using that as a surrogate to say, well, the other sites have probably responded too. And ctDNA is probably going to be a much better way of looking at MRD than PathCR. And there's data from Niagara which kind of supports that. It's quite robust data from Niagara that supports that. So the principle of surgery and PathCR and response is becoming one of these areas where we're beginning to ask serious questions about whether we need to do the surgery at all. What trials should we do to ask the question about whether we need to do surgery? Carla, do you want to start?
Sure. I mean, I think that, we have
Are we there already?
sort of. I mean, I think we should be there.
So if a patient comes back, they've had a PathCR and they say, I don't want to have surgery, you want to say, fine.
Yeah, I mean, this is what we do in our practice already.
You give them radiotherapy.
We give radiotherapy.
You don't do nothing.
We'd never do nothing.
You'd never do nothing.
We'd never do nothing. We do either radiotherapy or radical cystectomy.
Matt.
So obviously, this is an area that we've been interested in for 10 plus years now. I think we have to proceed very cautiously. This is a major transition in how we do things, and we shouldn't be cavalier about omitting definitive local therapy. At the same time, we know for the past 40 years we're over-treating people, and if you swap out radiation for cystectomy, well, I'll tell you, you're still over-treating people. Irradiating bladders that have no cancer in them is also over-treatment. So I think there is a path here. We just need to, one, be quite careful about how we proceed, and two, ultimately, we need to determine whether or not randomized clinical trials in patients with a clinical CR to surveillance or maintenance systemic therapy versus definitive local therapy are feasible. And our Canadian colleagues are doing that in the Neoblast study, testing the feasibility of that randomization. An incredibly important study for how we move forward here.
Can I say something before we go to you, Jonathan, then you, Josh? Same question about this bladder sparing approach. The way I thought this trial, the neoadjuvant or peri-operative EV Pembro trial has changed the way I think about radiotherapy too. And the reason comes back to that issue is if we're giving the patients who are most in harm's way local radiation in the knowledge that 70% of them are going to relapse, people say, oh, we've got an 80% CR rate from the radiation, but that's different from chemotherapy. At least with chemotherapy, you can say, well, that's what she's doing in metastatic. In radiation, you're just giving it that area. So you might say, yeah, I've got 80% control in the bladder, but I've got 0% control in the rest of the body, and guess what kills people? It's the rest of the body. And so the role of radiation here, for me, is becoming very grey. If we've got very active systemic therapy that is controlling the disease, what is really the role of radiation therapy at all in bladder cancer right now? Jonathan.
So to answer that question, I mean, I think we don't feel always so confident that our clinical complete responses are truly pathologic complete responses. We hadn't in the past, in particular because the chance of a PathCR was a lot lower, right? In the 30s, at best, maybe the 40s in some settings, if we're lucky, 50. It's the PathCR rate is what's now changed the terms of the game, right? It's totally changed how we're thinking about this situation.
Has totally changed our thinking. That's where.
Yeah, I mean, it's totally changed how we're thinking about it. TMT after induction EV Pembro is a separate question I think we probably are going to need to answer, and how well is it tolerated? Do we need the adjuvant portion there? Is that, I mean, there's all sorts of things that, arise from that. We haven't proven that checkpoint adds to radiotherapy yet in bladder cancer anyway. It's a whole other scenario. But to get to your first question about how to design a trial, I think we have the opportunity to do it now that we have a highly potent systemic regimen. I think we kind of need to see 304 results to really understand, is it 3 versus 4? Because we're going to have to make a decision at some point, right? Where is the right point to make that decision that this is a person who can get bladder preservation? Is it after 3 cycles? Is it 4 cycles? Is it after 6 cycles? It's definitely not after 9 cycles. I don't think we're going to get tons of people to 9 cycles. So, can we refine our ability to predict, the biomarker of clinical complete response to get to that point?
Is 9 cycles the wrong number?
It's an arbitrary number.
Is it the wrong number?
I don't know. I literally, I think it might be too much for most patients.
But you
and
would
not
recommend
some.
currently until approval, you would recommend?
Yeah, I mean, I think this is the way the data is. We're stuck with it. I didn't design the trial.
And Josh, I guess the last question for you, and then we're going to wrap up with that last question about what the future trial should be in this space. In the bladder sparing space, the oncologists are beginning to say, we would like to take control,
Yep.
and we would like to do bladder sparing approaches. Carla says she's doing it now.
Yep.
I know many people in Europe are doing it now. Many of my friends in America and academic institutions are talking about it. What's the surgical community going to do about this?
Yeah, so it's about the patient and their risk right now. So again, that's why the first step when I have an MIBC patient is to the medical oncologist. Because I think the best way to preserve a bladder is good systemic therapy. And then let's look and see how it responds. So our role in that is the readout. Unfortunately, we're looking at the bladder saying, is the cancer gone or not? Like, that's still our job, and we're going to play that role. But I think there's some people who don't want that risk. They don't want cystos afterwards. They don't want to follow that. So for them, they want the sure treatment. And right now, that's cystectomy. But in the future, for the right population of people, it's going to be complete preservation. But the question is, what's the primary outcome there? Is it recurrence? Is it event-free survival? Is it OS? I don't know what that primary outcome is going to be. That's the trial we need to design.
It's clear that there's not going to be a one-size-fits-all answer in these scenarios, right? This is adaptive therapy. We're making decisions based on intermediate endpoints to decide what the right course of treatment is. And we haven't really been doing that in bladder cancer because we haven't had good intermediate endpoints, or we haven't had effective enough systemic therapy.
And I think, I was just going to say, I think it really highlights the need for a multidisciplinary approach for care even more now than before, right? Because you do need to bring in the urologist, need to bring in the radiation oncologist, to bring in medical oncologist, put it all together and figure out what's the right approach for the patient. The other thing I worry about is if we do nothing to the bladder, which may be in the future, how many cycles do we carry on with systemic therapy? I mean, do we do 9 cycles and then we maintain with Pembro and we just keep it going? Or is there a point when we actually
Well, what about radiation therapy is not doing anything?
Sure.
That
Yeah.
doesn't sound great either.
Fair.
Okay, so we're going to look at that trial design, which I talked about. I'm going to let each of you say what you'd like to see next in perioperative bladder cancer. Ideally, I'd like you not to agree with the person before you. So it makes it more difficult for you, Josh, at the end. I'm going to start. I'm going to make it really easy. We just do a big single-arm trial, bladder-sparing approaches. We do 9 cycles. We show that patients don't need to have radiation therapy or surgery. Single-arm trial. Carla.
I think I would sort of mimic what we do normally in our clinic, where we give EV Pembro upfront, neoadjuvant, and then we let the physician, the patient, the radiation oncologist, the urologist decide what local treatment to give, and then give adjuvant. Right now we're at 9 cycles. And you're really asking the question, what do we do locally for the bladder?
So we've got a local therapy with radiation. We've got an unselected one-size-fits-all, 9 cycles. Matt, what we got?
So we're doing the study that you brought up. We designed it in 2021, EV Pembro, clinical complete response, bladder preservation. The large part is the missing part with our study. It's not a huge study. It's an investigator-initiated study. So yeah, I think we need bigger studies in that space. I think that's the present. When we think about the future, I think then we start to do response-guided treatment in a slightly different way. And I think, to your points about the role of radiation and other therapies, I think there are nuances in terms of local disease that not all local disease is the same, right? So a patient who has a clinical complete response, has detectable UTDNA, has undetectable ctDNA, maybe radiation for that patient. So I think the response-guided treatment paradigms are going to evolve further with some newer tools.
So we've got Tom, one size fits all, do it 3, do it big, do it fast, get it done. We got Carla with some nuances with local therapy. We've got Matt incorporating UTDNA and ctDNA into the paradigm. Jonathan, it's getting more and more difficult. New drugs.
Yeah, I guess that's really the next question. Have we reached the pinnacle of therapy with enfortumab and pembrolizumab? If it never gets better than that, I'd love to see 90%, 80% response rates. I think the new drugs that are coming at us for new checkpoints, the PD-1 VEGF inhibitors, the bispecifics, some data with the PD-1 TIGIT at ESMO, very interesting. So I think, can we improve on the results we've gotten? Another twist, although I don't know that this is the right trial, is that we do know that some of the non-responders do respond to platinum-based chemotherapy. And so, don't necessarily, the non-responders, perhaps a treatment switch is the way to go, as opposed to just saying, well, we're going to take your bladder out now. That might be the right, And so I think there's some ways to change this with some new agents and some new thinking about how to use the existing drugs we have.
So we've got one size fits all. We've got some radiation therapy. We've got ctDNA, utDNA. We've got new drugs. Josh.
Yeah, can you omit systemic therapy? I'm going to go all the way back to the beginning. ctDNA negative, can you, taking it away from the MENA, can we put something in the bladder, again, let's say Alexo, TAR-200, for people that are ctDNA negative, so localized disease, keep your bladder, single arm, and avoid systemic therapy.
So 9% of people on Keynote 905 cured with TUR, right? Who are those patients?
Right. But then you add a strong local therapy and follow, again, ctDNA, and maybe avoid systemic therapy.
And Josh, what was your take on, and we're going to end it very soon, what was your take on the pretzel in Sunrise 4, muscle-invasive disease, the data we saw at ESMO? Do you feel this has a role in muscle-invasive disease? Or surely with the 905 results, we just don't need to worry about what.
Well, I love how Andrea presented it with the biomarkers, because do I think it's for every patient? Would it be good for the EV303 patient? Probably not, but there are some people who you can likely keep a hold of their cancer with that therapy combination.
I think with that, we're going to call it. Many thanks for your time.